Hey there, future mental health superheroes. Welcome back to the deep dive.
Hello, everyone.
And a special hello if you found us through the amazing community over at Book Podcaster. We're really thrilled to have you join us.
It's always great to be here, yeah, especially when we're tackling, such crucial topics for the next generation of nurses.
Absolutely, because let's be honest, those nursing textbooks,
Huh?
they can feel like they weigh more than you do
Yeah,
sometimes.
yeah, they can be dense.
Right. That's where the deep dive comes in. We're here to sift through the essentials, kind of pull out the really valuable insights, and make it all a little less, well, textbooky.
Yeah, think of it as getting the key info, but hopefully in a way that sticks.
Exactly, like the Cliffs Notes version, but way more engaging, we hope.
Precisely. Our aim is to make these fundamental concepts not just understandable, but um, really memorable and applicable to your future practice.
And today, we're zeroing in on our real cornerstone, Chapter 8 of Townsend Morgan's Psychiatric Mental Health Nursing, the 10th edition, specifically the nursing process in psychiatric mental health nursing.
Yes. This chapter is truly the bedrock. I mean, the nursing process is vital everywhere in nursing, obviously,
Hmm.
but its application in mental health, it just has this unique depth. You're engaging with the complexities of the human mind, emotions.
Yeah.
It demands a really thoughtful, structured approach.
Exactly. Assessing a patient's mental state isn't quite the same as taking their temperature, is it?
Not at all. Different skill set required.
It requires a different kind of attention, yeah.
Yeah.
And we know how much information you're juggling as nursing students. Oh my goodness. So our goal today is to unpack this chapter in a way that's clear, concise, and maybe even a little bit fun.
We'll try.
Yeah.
So let's jump right in. At its core, the nursing process provides a systematic way to organize your thinking and your actions when caring for patients.
Okay, let's unpack this. Why is having a structured process especially important when we're talking mental health?
Well, because in psychiatric nursing, you're often working with the internal experiences of the patient, right? Their thoughts, their feelings, perceptions.
Things you can't always directly see.
Exactly. So a structured process helps you gather that information, the psychological, emotional, social, behavioral stuff, in a systematic way. Then you can, make sense of it and develop a care plan that actually meets their individual needs. It's about bringing clarity to often complex situations.
That makes perfect sense. So what are the key steps, the roadmap, so to speak?
There are 6 core steps: assessment, diagnosis, outcome identification, planning, implementation, and evaluation.
Okay.
Think of them as a continuous cycle. They guide your interactions, your interventions.
6 steps sounds manageable, but I'm guessing it's more than just like ticking boxes on a checklist.
Oh, absolutely. This is dynamic. It's relational, as the chapter really emphasizes. It requires sharp critical thinking, sure, but also genuine empathy, connecting with patients on a human level. And flexibility. You need to adapt your approach as you learn more.
Okay, all right, let's dive into step 1 then. Assessment. What exactly are we trying to gather here?
Assessment is all about collecting comprehensive data, building a complete picture, really, of the patient's current state. It involves several key areas.
Lay them on us. What are the essential
Okay, well, a crucial component is the mental status exam, the MSE.
MSE, right?
It's a systematic way to describe their current mental state. You look at appearance, behavior, speech, mood, affect, thought process, thought content, perceptions, cognition, insight, judgment, lots of pieces.
Wow, okay.
You'll also gather a thorough psychosocial history looking at their past experiences, relationships, how they've coped before, their support systems.
So it's like putting together a puzzle of their life and their current mental state.
Exactly. And then there are risk assessments. These are critical, particularly focusing on suicidality and any potential for regression.
Safety first.
Always. You'll also use standardized screening tools, things like the PHQ-9 for depression or the GAD-7 for anxiety, the Columbia Suicide Severity Rating Scale.
Ah, the standardized scales.
Yeah, these give you quantifiable measures of symptom severity, so you can track changes, see if interventions are working objectively.
Makes sense.
And it's vital, really vital, to consider their family background, their cultural context, any spiritual beliefs. These significantly shape their experience of mental health.
Can you give us an example just to make it really concrete?
Sure. Imagine you're assessing a, let's say, 38-year-old man with a diagnosis of schizophrenia.
Okay.
You might observe maybe limited eye contact. He seems to be responding to things you can't see. Internal stimuli, his speech might be disorganized, hard to follow, and maybe he reports hearing voices. auditory hallucinations.
Okay, I can picture that scene.
So your assessment involves noting those observations. Those are your objective findings,
Yeah.
but you're also assessing his insight.
Yeah.
Does he understand these are symptoms?
Right. Does he get it?
What's his judgment like in everyday situations?
Mm-hmm.
What's his affect, his outward emotional expression? And crucially, what kind of rapport can you build with him?
How you connect.
Yes, all of this gets documented. And here's a really interesting point from the chapter. S Psychiatric assessment is often described as like 80% observation and listening.
80%.
Yeah, and only about 20% direct questioning or interview technique.
Wow.
It really highlights how important your nonverbal skills are, creating that safe space.
Yeah.
Sometimes that tells you more initially than firing off questions.
That's a powerful reminder, just being present. Okay, so we've gathered all this crucial info. What's step 2?
Step 2 is nursing diagnosis. Now, it's really important to get this distinction. This is different from a medical diagnosis like schizophrenia or bipolar disorder.
Okay, how so?
A nursing diagnosis identifies the patient's responses to those mental health challenges.
Yeah.
So, simply put, the medical diagnosis is what the doctor says the illness is.
Yep.
The nursing diagnosis is how that illness is impacting the patient's life and what we as nurses can directly address.
Ah, that's a critical distinction. So it's not just the label, but the effect on the person's functioning, their well-being.
Exactly. The chapter lists common NANDA-I diagnoses you'll see, things like risk for suicide, disturbed thought processes, ineffective coping, social isolation, powerlessness, anxiety, disturbed sensory perception.
Those all sound like very real, very human struggles that nurses can actually help with.
They are, and Townsend emphasizes this. Nurses identify nursing problems related to the medical diagnosis. So, for example, someone with bipolar disorder might have a nursing diagnosis of sleep pattern disturbance.
That makes perfect sense. The medical diagnosis provides context, but the nursing diagnosis guides our specific nursing actions. Can you give us another example?
Sure. Think about a patient who's experienced significant trauma, maybe has PTSD.
Okay.
You might observe they consistently avoid crowds, they're plagued by nightmares, and they get really distressed if you try to talk about the trauma. A corresponding nursing diagnosis could be post-trauma syndrome, related to witnessed violence as evidenced by hypervigilance, avoidance behavior, and intrusive thoughts. See how it connects the behaviors, the evidence, to the underlying issue.
Absolutely, very clear. Okay, we've assessed, we've identified the nursing diagnoses. What's next? Step 3.
Step 3 is outcome identification. This is where you define measurable, realistic goals for each nursing diagnosis. And ideally, you do this with the patient whenever possible.
Collaboration is key.
Their input is invaluable. It fosters buy-in.
Teamwork makes the dream work, even in goal setting.
Exactly. And to make sure these goals are effective and trackable, the chapter introduces SMART goals. Specific, measurable, achievable, realistic, and time-bound.
Ah, the SMART framework, a classic for a reason. Can you give us some SMART goal examples in a mental health setting?
Certainly. For someone struggling with anxiety, a SMART goal might be: patient will verbalize 2 healthy coping strategies for managing anxiety by the end of week 1.
Okay, specific, measurable, time-bound.
Exactly. For someone with insomnia, patient will sleep at least 5 consecutive hours per night within 3 days. Or for social isolation, patient will attend 3 group therapy sessions this week.
Those are great, really concrete, and that measurable part seems so critical. Otherwise, how do you know if you're actually getting anywhere?
Precisely. And documenting progress towards these goals. The chapter stresses how essential that is for evaluating if the care plan is working.
Okay, we know where we want to go with the goals. Now, how do we map out the journey? That's step 4, planning, right?
You got it. Planning is designing those individualized nursing interventions, the specific actions you'll take to help the patient achieve the outcomes. This is where your clinical knowledge, your creativity, it all comes together.
What kinds of interventions are we talking about in psych nursing? Seems like it could be broad.
You can be quite diverse, yeah. Establishing a strong therapeutic rapport, that's always the foundation.
Always number 1.
Then you have things like administering and monitoring psychotropic meds, teaching specific coping skills like deep breathing or mindfulness, developing crisis prevention plans, collaborating with the team, social work, psychiatry,
Right, the whole team.
and providing psychoeducation for the patient and often their family too.
Psychoeducation, helping them understand their condition, the treatment.
Yeah.
That sounds incredibly empowering for patients.
It really is. And Townsend makes another really important point here. Planning must be sensitive to the patient's cultural and spiritual background.
Ah.
What works for one person might be totally inappropriate, even harmful, for another based on their beliefs, their values. You need that truly individualized approach.
Absolutely. Seeing the whole person, not just the diagnosis. All right,
Wow.
we've got our plan. Step 5 is putting it into action. Implementation.
That's right. Implementation is carrying out those planned nursing interventions. This covers a huge range of nursing actions in the mental health setting.
Paint us a picture. What might this look like on the floor?
Okay, you might be engaging in therapeutic communication, really active listening, offering support. You could be leading a group therapy session, maybe facilitating activities in the milieu of the therapeutic environment.
Uh-huh.
You'll be making sure patients take their meds as prescribed, monitoring for side effects, watching for any signs they might be decompensating, getting worse.
Vigilance.
Yeah, and patient safety is paramount.
Yeah.
So that might involve putting suicide precautions in place or, in very rare, carefully considered situations, using restraints if it's absolutely necessary to prevent harm.
Right.
And with consent, involving family in the care can be a really crucial intervention too.
Can you give us a quick scenario? Implementation in action.
Let's go back to our patient with schizophrenia. Say they start withdrawing, isolating in their room, refusing meds.
Okay.
The nurse's implementation might involve increasing the frequency of brief one-on-one check-ins, just trying to build trust, understand why they're refusing, maybe use some motivational interviewing techniques to explore their feelings about the medication.
Trying to understand their perspective.
Exactly. And then collaborating with the psychiatrist, maybe the dose needs adjusting, or the way it's given.
So it's not just checking tasks off a list, it's being responsive, adapting your approach constantly based on what the patient needs right then.
That's it, exactly. And the chapter also points out implementation includes knowing what not to do,
Oh, interesting. Like what?
like avoiding power struggles,
Mm-hmm.
or using non-therapeutic communication, things that could just escalate a situation or shut the patient down.
That's a really valuable point. Sometimes the best action is knowing when not to push or how to approach things differently. Okay, implemented the plan. Now, the final, crucial step. Evaluation.
Step 6, evaluation. This is where you measure how well the patient progressed towards those goals you set back in outcome identification. You're basically asking, did our plan work?
Right.
Is it effective? Do we keep going? Do we need to tweak it? Or have they met the goals and we can maybe step back the intensity of interventions?
So how do we actually measure that progress? What tools do we use for evaluation?
It's a mix of things. The patient's own self-report is huge.
Yeah.
How are they feeling? Are they noticing improvement?
Subjective data.
Yes. Then your own observations of their behavior, objective data.
Yeah.
Are they interacting more, sleeping better, showing fewer signs of distress?
Uh-huh.
You might re-administer those standardized tools. Did their PHQ-9 score go down? That gives you objective evidence.
Okay.
And feedback from the rest of the team, and sometimes family, can also provide really valuable insights for evaluation.
Can you walk us through an evaluation example?
Let's use that goal we mentioned.
Right.
Patient will report decreased auditory hallucinations within 1 week.
Okay.
At the end of the week, you evaluate. The patient reports, well, I still hear the voices, but now it's mainly just at night. They also mentioned they've started using headphones with music to cope when the voices start. And they've asked about learning more about cognitive behavioral therapy, CBT.
Okay, so definitely some progress, but not fully resolved.
Exactly. The evaluation shows partial progress. So based on this, you wouldn't just discontinue the plan, you'd revise it.
How so?
You'd focus the plan more specifically on providing support and teaching coping strategies for managing those nighttime hallucinations, since that's the remaining issue. Maybe explore that interest in CBT.
That really highlights the cyclical nature, doesn't it? It's not linear, it's ongoing. Assess, act, reassess.
Precisely. It's a continuous loop. It ensures the care stays relevant and responsive to the patient's needs as they change.
Okay, so quick recap again. Assessment, gather info. Diagnosis, identify needs. Outcomes, set goals. Planning, figure out how. Implementation, do it. Evaluation, check how it went and adjust. Got it. Now, can we put it all together? Maybe a real-life clinical scenario?
Absolutely. Let's take a case. Imagine a 27-year-old woman brought into the ER by paramedics. She attempted suicide by running into traffic. She's visibly distressed, crying, saying things like, I can't do this anymore. There's no point.
Wow, okay. A very acute, high-risk situation. Let's walk through the nursing process here. Initial assessment focus.
Safety is number one, absolutely. Immediate assessment confirms she's at high risk for suicide. No known psych history. Recent stressors. Lost her job, and a serious relationship just ended.
Diagnoses.
Huge. A quick mental status exam might show a flat affect, maybe poor insight into the danger of her actions, and she keeps making these high-risk statements about wanting to die.
Okay, so risk for suicide jumps out immediately from the assessment. What nursing diagnoses follow?
Based on that initial data, yeah, primary nursing diagnosis is definitely risk for suicide related to hopelessness and those recent losses. You'd likely also add ineffective coping related to her inability to manage the distress from the job loss and breakup.
Makes sense. What about initial outcome goals in this critical phase? Short term.
Very short term, focused on safety, for example. Patient will verbalize understanding of a safety contract and agree not to harm self within 2 hours. Maybe a slightly longer but still initial goal. Patient will identify one personal reason to live within 24 hours.
Crucial first steps. Building safety, finding a glimmer of hope. What's the nursing plan at this point?
The plan has to involve placing her on constant one-to-one observation. Immediate safety.
Eyes on at all times.
Yes. Then engaging in more in-depth safety planning. What are her triggers? What coping skills has she ever used, even if they aren't working now? And critically, the plan must include an immediate consult with the psych team for a full evaluation, maybe medication consideration.
Okay. And how do the nurses implement that initial plan?
Implementation means staying with the patient constantly, building some basic rapport, just showing you're there, removing any potential self-harm items from the environment, sharps, belts, cords.
Securing the environment.
Exactly. Offering supportive interventions, letting her talk, validating her feelings without validating the suicidal plan, maybe exploring any healthy coping skills she remembers from the past, even if it's just listening to music or deep breathing.
Okay. And finally, evaluation. How do nurses check if these immediate actions are working?
Within hours, and definitely by the next day, they're evaluating. Did she agree to the safety contract? Is she expressing less immediate intent to harm herself? Has she been able to identify any reason to stay safe, even just for the next hour? Or maybe name a support person?
Checking for small shifts.
Yes. The case example mentions that by day 2, maybe she's less tearful. She agrees to stay in the hospital voluntarily for treatment. She names her sister as someone she could call.
That's positive progress.
It is. And based on that positive evaluation, the team might cautiously decide to step down precautions, maybe from constant 1.1 to checks every 15 minutes.
Yeah.
But that decision is based entirely on the ongoing clinical assessment and evaluation.
Wow, that really brings the whole process to life. It shows how it provides that essential framework, especially in such a high-stakes situation.
It really does. And it underscores that point. The nursing process in psych care is just so deeply connected to understanding and responding to the patient's emotional, their psychological state.
Absolutely. It demands that keen observation you mentioned, that compassionate presence, and just constantly reassessing.
You're not just charting vital signs or lab results. You're tuning in to their fears, their pain, which is often unspoken, and also looking for those little glimmers of hope, those signs of resilience.
And ultimately, like Townsend and Morgan emphasize, it's this thoughtful, systematic, and compassionate use of the nursing process that really separates good psychiatric nursing from truly great, exceptional care.
Precisely. It's how you make that tangible, meaningful difference in the lives of people who are facing really significant mental health challenges.
So to all of you dedicated nursing students listening, remember this. Mastering this nursing process, especially with all the complexities of mental health, it gives you such a solid, robust foundation for your practice.
It really does.
We know the studies are demanding, it's a lot to learn, but really getting these fundamental concepts down, it empowers you to give truly effective, truly compassionate care. So maybe take a moment after this to reflect on how you can start applying these steps, even in your learning right now or in your future practice.
And maybe that leads us to our final thought for you today. How does really deepening your understanding of a patient's unique emotional world, their inner landscape, how does that enhance your ability to apply every single step of this nursing process effectively? Something to ponder as you continue on your journey.
Thank you so much for taking this deep dive with us today. We really appreciate you spending your time exploring this vital topic. You've got this. Future nurses, keep learning, keep growing, and keep making that incredible difference.